So we've talked a little bit about some of the changes in MCH over time in research and programming and policy. What do you think, when you think about the leaders or the people that you've mentioned, some of the leaders in the program, what makes for excellence in MCH? What have you, when you think about that, what have you seen?
So you know, any point in time, there's always going to be great people to work with. When I went to Minnesota in 89, 90, and I don't even remember, but the way the Association of MCH Programs was organized, there were regional counselors. So whatever that region was, it was Region 5. Whoever the regional counselor was left or something. So they needed to fill in before the election. And my boss at the time came running down the hallway and said, "Hey, how'd you like to be the regional counselor for the association?" I'm like, "The who for the what?" So I said, "Sure, that sounds great." So I'm like 30 years old. I mean, and I go to my first meeting, and Peter Van Dyke from Utah, Bill Hollinshead from Rhode Island, Bill Buchanan from Arkansas. Just trying to think of some of these. The guy from New Jersey, I can't think of his name. But like these were giants in our field. People who both ran programs and had published. So you knew them because you read about them. You read their work. People who you'd heard speak at national meetings. I mean, just incredible people. And I remember we were meeting in Galena, Illinois, and I had gone out, and I forget what time the meeting started, maybe in the afternoon, and I'd gotten there early, and I was walking around, and so I'm a new mother, and I go in this little shop, and I find this really cool teddy bear for my daughter, and I came back, and I realized I didn't have time to go to my room. So I walk in this room with a teddy bear. They're like, "Oh, you must be Donna." The youngster from the Minnesota program. It was absolutely hilarious. But the conversations were just so rich. And I guess, you know, you start to look at these people, and here I am in a situation trying to understand what's going on, solve problems, be a good, you know, inspire my staff and work with different community. You know, it's a lot. But I think a lot of it really gets back to, you know, both the personal attributes that I think many leaders just naturally possess. Not that you can't learn them, I think you can. But, you know, great communicators, you know, very articulate, compassionate, empathetic. You know, they can, when you speak with them, you really feel like you're speaking with them, even though these are these, you know, giants in the field. You know, keeping your staff motivated and empowered to do the work that has to be done. Relating well to all the different constituencies. So being able to go to the legislature and answer crazy questions, and going to an angry group of parents or community folks, you know, being able to mollify that, understanding that it's not personal. I mean, I think that's something you have to kind of come to that on your own, but you do feel like you're being attacked, but you're not. You're just the embodiment of the thing that they're angry about. Being willing to speak your mind, understanding that, you know, not, you know, you may get fired, or you don't want to ever offend, but, you know, you want to be able to speak your mind. I remember being asked to be on a panel responding to an author, and he'd written a book, and I don't remember the title of the book, but the premise was people didn't need a hand. They needed they needed a staircase. Do you remember this? It was this notion that, you know, they just needed the steps. And he was a very good speaker, and I read the book. It was an interesting book. He talked a lot about the projects in Chicago and why that was a failed concept from the beginning. But then he really lashed out at public programs and the government and how we made these horrible decisions. And so they wanted me to respond for it because I was representing the government. Somebody else was from a community. So he was clearly prepared for me to defend and argue. And I said, well, I actually believe he's absolutely right. Everyone kind of looked at me. And there was a huge crowd. It was a public forum. And I said, but, you know, what I want the people in the room to understand is what the government does. They represent you. And they act on your behalf. And they listen to you. You may not believe that they listen to you. So let's talk about the Medicaid program or the SSI program. Remember the whole crazy check thing? I think that was what was going on at the time. I said, so you out there said that you didn't want anyone who wasn't deserving of that program to get that program. That's what you said. Well, the only way we can guarantee that no one slips through the cracks is to set up such burdensome and onerous screening requirements, because otherwise how can we, and those people are out there and they're always going to find a way in, and then we have to add yet another, which makes them expensive. They're administratively expensive. They're challenging for people. So the end result is many, many people who could benefit from these programs, who are technically eligible for these programs, don't get in these programs. And they end up being a burden. They end up in your emergency rooms, all the things you say you don't want. But you've made it loud and clear. You didn't want anybody not eligible getting in that program. And it was like people were just looking. This author was clearly deflated. He was ready for a fight. He was just itching. And I said, no, I agree with you. You're absolutely right. But you have to understand where these things come from. Bureaucrats don't sit in their offices and dream up ways to make your lives, horrible. We respond to what you tell us you want, and that's what you said you want. Now, personally, I'd rather let a few, undeserving. Who's undeserving? Especially when we're talking about children. It's ridiculous. But I forget what question you asked me. Leaders. So leaders, I think leaders have to really understand what the vision is that they're trying to do. They have to keep their eyes on that vision. They have to motivate the people around them, be able to engage people. And the leaders I've had the great fortune to work with over the years, I've watched and learned, and not taking it personally, and picking yourself back up and going back in the arena, because that's your job. That's your job.
What do you think the challenges facing MCH? We don't have enough time in the world for you to actually, as I'm asking the question, I'm thinking, what are the challenges?
At what level?
I know. If you think about students watching this interview and preparing future MCH professionals and leaders, what are the things that you would want them to know to look at the challenges that are facing us?
So let me say one thing that I should have said before that relates to this, which is the other big change I've seen in my lifetime is the reemergence of the data as driving decisions. And people that have heard me before, the charge to the Children's Bureau in 1912 was to investigate and report on all matters pertaining to child life and welfare among all classes of our people. But the important part is investigate and report on. The initial charge of the first federal agency in this country devoted to children was to investigate and report. That meant collect the data, analyze it, and disseminate it, report it. And we went through a period there, the dark days, where there was no data reporting required, budgets were cut, all the data people went away, and that was horrific. And I think those of us who lived through those days know that you don't ever want to go back there again. Because without data, yours is just another opinion. And that doesn't mean the data, everybody reads it and goes, oh yes, this is obvious, this is what we must do. I don't mean that at all. But without it, you're naked. And so I think when we think about, that's one of the biggest challenges we face, I think, is having the right information when we need it to make the decisions that we need to make, to advocate ethically and responsibly, and not just shooting from the hip. So I just wanted to make that point. But I think the other thing is, and I'm not even sure how to say this because I don't think it's a concept any of us have fully figured out yet, but this notion of life course in systems, this whole system thing, we're still trying to get our arms around that, to really understand what it means and how it works. But if you're going to be an effective MCH professional at whatever level you're at, you've got to understand that. You've got to be thinking about it. And chances are you'll have some job that has some defining characteristics. Like even in Minnesota, the reproductive health person, that was her focus. But she still had to think about everything that that potentially impacted on that population, and the good and the bad. And so that means if you're going to be effective, an effective professional, you've got to understand those things. That means you've got to reach out and get to know those people. That means you've got to understand where the leverage points are, where the opportunities are. There was a wonderful, I love these little studies. It was done by the Public Health Foundation, which is the research arm of the American Public Health Association. This was in the 80s. And the leaders of the government agencies, HRSA, it was ATMCH at that time, now it's SAMHSA, the Alcohol, Drug Abuse, and Mental Health Administration, HCFA, Healthcare Finance Administration, which is now CMS, right. ATMCH now, ATMCH, SAMHSA, HRSA is still HRSA. But they had kind of gotten this notion that, kind of what I was saying before about the youth offenders, that we all probably know the same people, that we're treating the same people, we're paying through Medicaid for substance abuse treatment, through primary care centers, through, you know, these, and so why weren't we sharing data was the question at the time, you know, because maybe we could be more efficient. We could be more efficient and maybe provide more optimal care. So the question was, you know, why don't we share data? And they put the survey together, and was it hardware incompatibility? Was it software incompatibility? Was it that we don't define our terms the same way? Is it, you know, blah, blah, blah. Well, it turned out, all surveys collected, that the one thing that mattered was if you had a personal relationship. If the data guy from one agency had a personal relationship with the data guy from the other agency, they'd find a way to share the data. Didn't matter if it was completely incompatible. They'd find a way. So to me, that's just saying that, you know, a lot of it really boils down to personal relationships, your interpersonal skills, your ability to communicate effectively, your ability to be somebody people want to work with. And, you know, you can't really stress that enough. If you're not someone people want to work with, you can forget ever building relationships across components of the system. It's just not going to happen. And sometimes that means being quiet. Sometimes that means not getting what you want out of an encounter or a series of encounters. Sometimes it means you have to give something in the hopes that you'll get something back later down the line. You got to negotiate, and sometimes you got to take the fall for somebody. But if you don't build those relationships, you'll never get what you need. So, you know, and sometimes people say, God, you know, why haven't you? Well, because that problem that looks so simple to you. I mean, here's an example. What could be simpler than giving a child a vaccine? Right? Isn't that a straightforward public health intervention? I know what it is. I can count it. I can say, right, that's easy, right? There's nothing easy about getting a vaccine into a child. Nothing. Nothing. And I don't have to tell you. But think of all the things that have to happen and be in place for that child and that needle to meet. And vaccinations are pretty simple. When you talk about preconception care or, you know, service system supports for children with multiple, you know, complex medical conditions, I mean, it makes your head hurt. So in some ways, you gotta be willing to, you gotta be tolerant of ambiguity. Gotta be willing to kind of live in chaos. You won't always have all the information you need, and sometimes you gotta take a back seat because, you know, you gotta maneuver. And all that, and you still have to have all the data. You still better know the science. You know, you still better, you need to know that. You might never play that card, but you better need to know it. I mean, you better need to know it. You better know it because you're going to need to know it. Because if you're ever asked, then you have to produce. So I don't know if I answered your question. It's
that's right. Actually, I was going to ask you, and you probably did. What do you wish you had known? I mean, now, being here right now, what do you wish you had known about the field of MCH or the skills you needed to be an MCH? What do you wish you'd known that you know now?
Well, I think a lot of it, you know, you can't know because it comes with maturity. You know, how to separate yourself from the situation, how to take your ego out of the equation. And people can tell you that, but until you get smacked around a few times. So part of it is I think you have to kind of learn those things. But I think that's critical. And I've worked with people who never learned that lesson. I'd say, that had nothing to do with, what are you upset about? That had nothing to do with you. You know, really, I mean, it's like, I'm kind of flabbergasted. I wish I knew more about, not so much the legislative process, I get that, but really how the people think in those positions. It took me a while to figure that one out. And I think part of it's understanding how to communicate to different groups of people and not be insulting or patronizing, but just understanding people are going to come at this from a different level and different place. I was well prepared. I mean, that's part of that's why I'm having a difficult time answering your question. I was extremely well prepared. That program was phenomenal. My master's program was phenomenal. Partly because it was a brand new program, as I said, and they kind of ran around behind us, hovering, making sure and because it was a brand new program and they hadn't really sorted out what they wanted us to do yet, they had us do everything because they didn't know what to have us do. So we went to, there was a doctoral student class. This is why I never wanted to be a doctoral student, by the way. Every Wednesday afternoon, 24 months out of the year. It felt that way. 52 weeks out of the year, every Wednesday afternoon, doctoral students, every member of the faculty would be there. And the doctoral students, they would rotate, and wherever they were in the rotation schedule, they presented where they were in their research. So if they were just creating, coming up with ideas, or if they were at the protocol stage, or wherever they were. And new doctoral students reviewed research grants. They critiqued research grants. So they said, well, what do we do with these? And there were 2 of us in this program. What do we do with these 2 Master Health Science? Well, let's let them do that too. Let them go in there, and it's completely insane. But boy, did I learn how to write grants and review grants, because it's all about validity. What else did they have? They had us do all kind of, we took the doctoral comprehensive exam because they didn't know what else to have us do.
Wow.
They did very well, thank you.
Good for you.
Just the curriculum was intense. It was incredibly intense, but it was so exciting to me. And my friend who was there with me, we were the same way. So we weren't working because we figured there was no way. So we just took everything we could take and learned everything, and these incredible people. And then I mentioned they were so well connected to the local government, the local health system, the state government. So we got a lot of exposure, which I think is really important in master's. I don't think we do enough of that at a national level. I think we do a better job at USF than other places do. And then, I did a 6-month full-time field experience at the Office of Disease Prevention and Health Promotion in Washington, D.C., and worked with some of the incredible leaders of the time. Again, this is the 80s. This is, they just wrote the first Healthy People. They just had the first set of objectives for the nation. And this office is the one that managed all of that. They knew I was interested in MCH, so I got involved in the National Healthy Mothers, Healthy Babies Coalition. I spent time at the Bureau. I was in HRSA. I worked with the Office of Public Affairs. I manned the HIV hotline that Ed Brandt and Chick Hu put together. I mean, it was just an amazing, I was so well trained. So well trained. I don't think everybody has the benefit of that experience. And then working, as I said, working through my doctoral program with these regional projects, working with 6 state health departments on a whole array of different projects. The grants were set up to provide sort of collective training on topics that they agreed to, and then specific technical assistance. And then we would always write a report, because maybe you don't have that need today, but you might have it tomorrow. And so we produced this volumes of material. We spent a lot of time in these states, and I really got a feel for how state MCH programs work and the challenges that they face. So when I got to Minnesota, even though I was young, I just had a whole lot of experience. So when you ask me that question, the things that come to mind are more personal. I had to learn, Donna, that wasn't very nice. I had to learn patience, really, and taking a back seat, letting someone else have the glory. That stuff's hard. It's hard. But I think if you're going to be effective, all the knowledge in the world, all the data in the world, if you can't get it somewhere, then it's useless. So it's both, kind of the hard stuff and then the soft stuff. And the soft stuff, staying up all night at a hearing at the legislature, in case they call on you, and when they call on you at 5 a.m., what? You want me to do what? But you learn. You learn those things.
Charlie Mahan, who talked to us last week about his experiences and his recollections about MCH, talked a lot about, you know, his experiences were different, but he came to a lot of the same kinds of conclusions that you did. And he talked a lot about the data and how important it is that we have data to drive what we do. And he talked about different MCH sort of specialists, you know, that we need people in different areas to have expertise, and that the expertise and the data makes such a difference to us. And then he talked a lot about coalition building. He did a lot of work, as you know, working at both local and state, and then federal coalitions, but he did a lot of state work. And it seems to me that from what both of you were saying, that's a skill.
Absolutely.
That we really have to.
Absolutely. No, I'm glad you said that. Yeah, because again, even the vaccine, you know, even what seems like a simple intervention, a good coalition can make that happen where it won't otherwise. And because so much of what we do is so interrelated to everything else going on out there, and because we're competing for resources and attention and time and everything else, getting a group of committed people together to really work on something with you is huge. And if you're in the public sector, if you're working in the public sector, you often are very limited in what you can do or say. Or, you know, I've been in, you know, moments where I had total freedom to go talk to legislators, testified, nobody reviewed what I was going to say, you know, to the extreme opposite where, you know, I wasn't even allowed to drive by the building, you know, because I might look at it sideways and convey something that somebody didn't want conveyed, and everything in between. And so, you know, I sometimes get frustrated with my colleagues, but then I remember, no, I mean, they may be in a situation where there's simply nothing they can do about it. You can't, you know, yeah, you wanna take risks and speak out and do the right thing, and yeah, you might get fired, but boy, you don't want to get fired if you don't have to get fired, because people are depending on you to do these jobs, and sometimes you simply can't speak or act or do anything. Well, that's not the time to go out and say, hey, I need to build a coalition because I need you people to be my voice. You know, it's way too late for that. You build it way back when, and you have it ready and mobilized and activated. And when it's working right, you don't have to do a thing. They go on their own, and they know what the message is. You've given them the data. They know, and they bring their passion and their spirit and their own stories. And you know, in the policy arena, there's nothing like a good story, you know, a heart-wrenching story to motivate people to act. Even, you know, especially if they're on the fence, you know, something that gets to their gut, their heart, they'll act on. And we can't do that. I'm the state MCH director. I can't go in there and tell them some sob story. That's not my job. But that's what I have all these other people there for. And so if you do that right, they not only are helpful to you in the formulating of the ideas or coming up what's going to work in this community, but then, boy, when you want to move to action and get resources, they're indispensable. You can't do it without them. So yeah, I mean, people that haven't figured that out, yeah, that would be one of those critical skills that you have to, if you haven't figured that out, you're in trouble. But I told you, I was sort of raised by groups of lone wolves, and you know, by groups of coalitions. I mean, I've worked with some of the best in Maryland. These women were, and it was predominantly women that ran these coalitions because they were women's issues. But we had a lot of really good, strong men get involved too, like Ron. I'm going to think of his name before the end of this, and a couple others that just kind of came out and said, you know, there's got to be more to this, because I pour my heart and soul into these patient encounters, clinical encounters. I give it all I got, and I'm not making a dent out there. And so that's the other good thing about coalitions, is they give people a place to go, to get involved, to get engaged, and to say, you know, I want to contribute in a different way. And then, you know, you can really do magic with those things. You know, people get excited and they'll volunteer their time, and people will give money to those things. They won't give money to the state health department, I can tell you that, but they'll give money to the coalition for whatever it is, childhood injury prevention or violence prevention or early childhood whatever, or preterm birth prevention, you know, people will, they get motivated.
That's great. Okay, any last thoughts that you would like to share about
me.
MCH? If you're thinking that this could either be to teachers of MCH, because this is going to be an innovative teaching tool, so teachers of MCH or students of MCH who might be watching it.
Wow, that's quite an opportunity. Oh boy, it's such important work that we all do. It really is important work. And like much of public health, we're not the only ones doing it. That's the other thing to remember. MCH happens all over the place. Which is why that systems approach is so important, why having data is so important. And you remember, we're often the only ones with any data. I mean, that's the other thing people forget. We get used to having it. And I might have told you this is somewhat off topic, but I did a study for Hillsborough County Commission, wanted to know about ER use among the patients that are served by the indigent healthcare plan in the county. Did they overutilize the emergency room? So they had this hypothesis that if you gave people who had not had insurance an insurance card, they would then overuse the emergency room because they now had access. So it turns out, as we hypothesized, that people really don't change their behavior just because you give them a blue card or a green card or no card or 3 cards. People overuse the emergency room all over the place. It's just sort of a function of lots of different things. But we analyzed the data. We used an algorithm that had been developed in New York State for ambulatory care sensitive conditions. You could really track when people were going to the emergency room when they shouldn't have, when they should have either gone to an outpatient center at that moment or had this treated a long time ago, and then it wouldn't have turned into an emergent situation. So the data, you know, we had graphs, we had charts, we had data tables, and a colleague of ours who helped me analyze that data, I said, well, you ought to come with me to the county commission meeting. So I'm presenting this, and of course there are as many opinions on that board as there are members of the board, and I got challenged all over the place, and people were questioning. And at the end of the however many, I don't know how long I was questioned, I turned around and this young man was just completely, I always thought data was just, it was just data. Like, it's just a fact. You know, I said that before, you know, well, you have the data, everyone will say, oh, yes, that's obvious. No, no. You have to have it. But that doesn't mean people suddenly go, oh, yes, I see. Yes, it's very obvious. Thank you very much. Now I know what to do. You know, it just doesn't happen that way. It just doesn't happen that way. But boy, you better have that data, and you better know what you're talking about when you go in there. But you know, I showed them the data, but I talked. I didn't say, now let's look at the third column from the, you know, geez, people's heads explode. And then I was at another county commission meeting down in Bradenton. And you know, it's the same kind of thing. You know, some of the questions you're just like, what in the world are these people talking about? But boy, you got to get in there and you got to do it. You have to do it, because that's what we're about. And MCH as a field, I don't care what people call it now. It's always going to be MCH to me. It's always going to be the Johns Hopkins School of Hygiene and Public Health too. Now it's the Bloomberg School of Public Health. Right. But, you know, again, conceptually, MCH has always been about the investments we make today for the future. And taking care of our children is, I think, the best job there is, because it's what we need to do as a society if we're going to sustain ourselves. And I think we've made a lot of mistakes. I mean, I think even you're asking about research, even understanding. And it was amazing when Peter Van Dyke, who was now the MCH Bureau Director, got up at a national meeting and said, you know what, I think we finally figured out that we can't solve in 9 months what a lifetime has produced. But didn't we think that? Oh my gosh, if we could only get these women into prenatal care, we could have a healthy baby. I mean, now it's ludicrous. When you think about it now, you say, why did anybody ever think that was a good idea? Well, it was a good idea because it was preferable to doing nothing, but it was so short-sighted. And I think we tend to kind of fixate on it. Oh, this is it. This is what we got to do. And you know, we have to be able to sit back and say, let's think about this a little more. So we need people that are good thinkers and passionate and motivated and not afraid to get dirty and not afraid to get yelled at, and can still go home and say, I did a good job today. I made a difference, because that's what it's about.
Thanks a lot, Donna.
Thank you, Dr. Daly.
Thank you, Dr. Petersen.